Good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audience in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Professor Daniel Provedillo. Professor Provedillo is the Vice Chair for Academic Affairs and the Director of Skull Base and Pituitary Surgery Programs at the Ohio State University Comprehensive Cancer Center. He is also the Chairman of the Skull Base Surgery Committee of the WFNS. He specializes in the brain and skull-based tumors and is a pioneer in endoscopic endonasal approaches and other minimally invasive techniques for brain tumors. He is only one of the few neurosurgeons in the world who have performed more than 1,000 operations in the form of EEAs. We are extremely honored to have him today at our webinars, and today we'll be talking about endonasal endoscopic approach for trigeminal schwannomas. The speaker for the second session of today is our honored guest. He is from Japan, Professor Hidetoshi Murata. Professor Murata is the chairman in the Department of Neurosurgery at the St. Mariana University School of Medicine, Kanagawa, Japan. He is also the visiting professor, Department of Neurosurgery at the Yokohama City University Graduate School of Medicine. He is the current director of the Neurospinal Society of Japan. He specializes in the management of spinal pathologies like spinal tumors and degenerative spine disorders. He is an noted author with several publications in various peer journals and is also on the editorial board of the prestigious journal Neurologia Medico-Chirurgica. And we are extremely honored to have him today at our webinars, and today we'll be talking about microsurgery for spinal intramedullary tumors. The chair for the first session of today is a distinguished faculty from Japan, Professor Takeo Goto. Professor Goto is a professor and chairman in the Department of Neurosurgery at the Osaka City University Graduate School of Medicine, Osaka, Japan. He is a very important member of the Japan Neurosurgical Society. He is a co-chairman of the Neuroendoscopy Committee of the WFNS. He has been an active member of the ACNS and has been an integral part of our delegation to various conferences and workshops organized worldwide. He has published several articles in various peer journals, and we are extremely honored to have him today to chair the session of Professor Provedillo. The chair for the second session of today's webinar is an honorable guest from China, Professor Gu Wentao. Professor Wentao is a consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai, China. He did his research scholars training from the Harvard Medical School, and he has hosted the National Natural Science Youth Foundation project, one provincial and ministerial level project, and published several papers in various peer journals. His clinical interest is focused in the diagnosis and microsurgical treatment of common diseases of neurosurgery, especially spinal cord and spine diseases. We are extremely grateful to him for accepting our invitation to chair the session of Professor Murata. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Takeo Goto.
I feel very honored to chair this webinar. Today, our great guest is Daniel Provedillo from the Ohio, USA. As we know, he is a very famous skull-based surgeon, microscopic and also endoscopic surgery. So I listened to his lecture many times in some meeting. Always his lecture is very educative and very fantastic, surgical video included. So today I think the all audience will enjoy his great lecture. Today, his topic is endoscopic endonasal approach to trigeminal schwannoma. So we are very happy to welcome the guest. Professor Daniel Provedillo, please start your lecture.
Thank you so much, Dr. Goto. It's really an honor to participate, and thank you so much for the entire society to invite me. So as Dr. Goto mentioned, what we will show here, it's a little walk around the philosophy, how we think about trigeminal schwannomas. I do think that the endoscopic endonasal, it's one of the main corridors or main approaches to take care of trigeminal schwannomas. But during this lecture, I'm going to try to show the different indications, different approaches that we can use. Interestingly, I do think that trigeminal schwannomas from all tumors of the skull base is the best one to really demonstrate the nuances of the different approaches, because the tumors of trigeminal schwannoma can appear from the brainstem all the way to closer to the face, all the way in the distal branches of the trigeminal nerve. So it's a very good sequence of tumors to understand the approaches. So when you look at different approaches, you can come into the skull base. You have all these options. We call anteromedial, which will be typically the endonasal approach, but of course can also be the glove or some more traditional ventral approach. You have the anterolateral, which is typically a transorbital approach these days. A lot of people are using those, or arterional as well, with the peeling of the middle fossa, more what I call a frontal orbitotemporal approach that you can come, or even an orbitozygomatic, like when you come in this direction, anterolateral. Lateral approaches can be used to the middle fossa. Very typically, you can just come below the dura of the middle fossa. And when we do an anterior petrosectomy, for instance, that's exactly what we do by lifting the temporal lobe and reaching the trigeminal area. Or what they very disseminated by Dr. Sami and Dr. Tatajiba, the RISA, which is when you come retrosigmoid, and you basically can drill out the suprameatal tubercle, and you can also get access to Meckel's cave by coming from behind. So we're going to show the nuances when we indicate one or when indicate the other. When you place trigeminal schwannoma into the Meckel's cave, it's very interesting how it can grow in different directions. And if you have a tumor, for instance, into Meckel's cave from a trigeminal schwannoma that projects medially anterior to the carotid artery, it actually has a contact with the sphenoid sinus. And this is what we called in several publications, we call the anterior door or the front door to Meckel's cave, is when we can coming with this anterior approach and basically open the front door here to enter Meckel's cave, which the other option would be the back door when you come from behind. So once again, it's all about the carotid artery. So I think this is very important when you're planning an approach, to look at the carotid artery. I learned these over the years, and I'm going to try to show you some of the cases I actually got frustrations in how I came up with this method of looking at the carotid artery. So if you have this projection medially here is when you have more possibility of coming endonasal. On the other hand, if you have a carotid blocking this corridor and the tumor is located typically in the middle fossa, not so large, that's when an anterolateral or a lateral approach will be more indicated. I don't see a reason to come on a retrosig if you don't have any component located in the posterior fossa. If it is purely in the middle fossa and the carotid is kind of guarding the visualization of the tumor from an anteromedial, then anterolateral or lateral approach will be better indicated. On the other hand, if you have a main component of the tumor located on the posterior fossa related to the cisternal segment of the trigeminal nerve, then coming with a retrosigmoid approach, it will allow you to get most of the tumor. And of course, a lateral approach also with anterior petrosectomy for some of those also would allow you to get those tumors. So you have to think more about lateral with anterior petrosectomy or a retrosigmoid to get access to that tumor located on the cistern. And if there's a combination, you can actually drill the suprameatal approach and get access to Meckel's cave coming from posterior. And sometimes you have tumors located on the more distal aspect of the trigeminal after it passes through the foramina, and those are the ones that can go into infratemporal fossa, pterygopalatine fossa, and then anteromedial approach also be indicated. So we'll look at some examples as well for each of these nuances and divisions. We have published this at Journal of Neurosurgery, and it's still something very important. And if you look at your MRIs and CTAs done before surgery, this can help you also to make a plan to see if it's a tumor that is more difficult or more feasible for an endoscopic endonasal. the position of the angle of the carotid artery will give you more or less access to the Meckel's cave. So if you have a hourglass type of carotid artery, we call this the type C Meckel's cave. This is when you have a more endonasal exposure to go into the Meckel's cave endonasally versus a carotid that actually lateralizes. And you will find, you see here in the anatomy, all these three variants, like that it's a type A, B, and C, and is really who is the carotid artery that dictates that type of exposure. So more lateral lacerum foramen with this orientation of the carotid will give you a smaller access versus when you have this hourglass where the carotids meet almost in the midline here, then you have more access to that Meckel's cave. And that's very, very well described in the literature, and it is something for you in your planning as well to take a look. So let's start with these tumors that project to the sphenoid sinus to give us some examples. And here's a patient that came to us with this type of tumor. And most of these patients, they usually manifest with numbness in the face, because the disease is from the trigeminal nerve. And frequently I see patients with a sixth nerve palsy because they push the sixth nerve up. As they grow from Meckel's cave, the sixth nerve gets stretched superiorly. And then you will see some more drastic symptoms. Sometimes these tumors can invade the orbit, cause blindness. And I've seen patients with seizures as well by having edema on the temporal lobe. But independently, when I see the patient with this entering, tumor is invading basically the sphenoid sinus, for me, this is a direct access to these tumors coming endonasal. See on the CT, that tumor, that bone is already thinner there. So I know this will be direct. Plus, in this case, there's a cystic component. See, this is T2. I'm going to pop this, there'll be fluid, and then I have a lot of space to take this tumor out. So all those things you have to plan. So for me, this was actually a very quick surgery that we did. And here's like several years later with the resection and never had a recurrence. We're just watching this patient. And so this is really to show the rationale of every case. You see, 4 years later, no recurrence. This is a picture that we took at a few years ago. This patient is probably now 8 years out, and there's no recurrence as well. So now let's see some of the variants here. So this is a patient, she was young, came to us. This is one of my early cases in my career. And I want you to pay attention to the amount of pneumatization that we see here. So that also is something I look, because I know I will have more space inside the sphenoid sinus. The window I have here it's not very large, but it's probably good enough. See, carotid is not in front of the tumor. There is a window here, and there's a lot of pneumatization. My main concern in this case will be the posterior fossa component. Is that possible to take it out? And that is something that you will see on the video. It was possible because of the amount of space and the fact that the carotid is medial and not guarding the tumor. So when we took care of this tumor, we did a transposition of the medial nerve. We didn't cut the medial nerve, which is very important to consider in these cases because these patients may have V1 numbness. If you have V1 numbness and you add a dry eye, then you can have problems with the cornea. Here is the moment where we're dissecting lateral to the carotid, and I'm moving from medial to lateral, and we were able to get that component of the tumor pop away from the posterior fossa into Meckel's cave. And we carefully dissected here inside Meckel's cave. You see V2 is preserved down here. So we open lateral superior to V2. The sixth nerve is superior on the field. And we were able to identify V3 inside Meckel's cave once we got these dissected. So if you look at the end here, this is the carotid that we removed the bone in front of the carotid. And here are the last pieces of the trigeminal schwannoma that we're taking it out. And you see the fluid, the CSF, coming all the way from the Meckel's cave in the back, from posterior fossa. And we were able to get that tumor mobilized from the posterior fossa. So if you look at here now, the final view, you get to see the V3 going down here with the motor fibers completely preserved, and that's Meckel's cave in the back, CSF coming from posterior fossa. So we were able to mobilize the tumor from that posterior fossa. And then here we'll put a collagen matrix inside the cavity, followed by the nasoseptal flap for reconstruction. Usually not a problem. You see median nerve still preserved at the end of the procedure down there. So this is the post-op. This patient did very well. Interestingly, this is a patient that had a herpes like after surgery, like a few weeks, a week after surgery, had this herpetic viral, this seemed like really impressive in her face with some sort of a herpes zoster manifestation from us touching the nerve. So there's something to have in mind. It's similar to when we do surgery on the facial nerve that you have a Bell's palsy afterwards, probably from reactivation of virus. We didn't have that with this patient, but then she recovered very well. So let's see another example here. This is a little larger tumor located on the Meckel's cave as well. Is this possible to take it through the nose? Most people probably will go with an open approach, but we noticed that this in the axial is the best way to see. There is this large window into the sphenoid sinus that allows us to enter here. And the component on the posterior fossa, not very large, with a wide area there. So let's take a look at this video. I'm not going to go through all the details here, but I think it's important. Maybe I'll let this video run a little more so everybody can see the steps. So here we are following the video nerve. So see, this is pterygopalatine fossa, and we follow the video nerve posteriorly. I didn't cut this video nerve as well. Once again, these patients have V1 deficit, so I work very hard not to cut the video nerve in order not to avoid a dry eye. You see the sella is here, and this is basically a continuation of the orbit with the superior orbital fissure that is here, and this is the carotid artery. So I'll let this video run so everybody can appreciate. So it's very tedious dissection. We work skeletonizing that carotid artery. You see here, we are removing all that bone, and we drill until it's very thin, and then we expose that periosteum. I'm going to move just so go here. You see the video nerve still preserved down there, and we're basically removing the bone. So see, this is the bone of that projection where the tumor is coming from middle fossa into the sphenoid sinus. Of course, you have periosteum in front of it. And this, then carefully, we skeletonize the carotid artery. So this is how we do. We make it very thin, and then I go with the Kerrison just to lift the bone. And if it is too heavy, then you stop, you drill a little more, and then until you feel comfortable, and then you rotate that bone out of there. So here's how we do, and you can see then we fracture, and you can then just take the bone out as is very thin, and that's better than just biting with the Kerrison. So that's safer because then you just dissect it away. And very important, we always use stimulator and monitoring of the V3 motor on these cases. I didn't mention before, but here I'm looking for V3 motor and the sixth nerve as I'm stimulating. So we're monitoring these cranial nerves, and I identify a window here that there's no sixth nerve because sixth nerve is running up in that direction. And this is the Doppler to make sure the carotid artery is here, identify the transition of the siphon of the carotid artery as well. And then once we get a silent area that there's no signs of any carotid and there's no stimulator, I usually open right at V2. See, this is V2 here, the maxillary. So I like to open there because it's safe. I know the sixth nerve is pushed up, and this is where we open there. So here we are dissecting and creating that window on the entry, the front door to Meckel's cave. So I'm very superficial with the ball probe. This is the dissector that I designed because it has this shape we call the Angelina dissectors, where it doesn't fight with the endoscope. It has that little curvature that doesn't fight with the endoscope. We'll go a little more here advanced. We're opening the dura. So here my question is always, where is the trigeminal nerve? Is it medial or lateral? And in this case, I didn't find any fibers here, and there was no much of a V3 motor. So I enter into the tumor, knowing that the sixth nerve is pushed up, and then I debulked internally the tumor. So a small window, here is debulking the tumor internally first, taking pieces. But the most important on trigeminal schwannomas is the ability to go around the tumor. See, I'm retracting, going around the tumor right there, finding the plane on the lateral part of the tumor after debulking, and also superiorly. So then superiorly, I use the stimulator. So I keep looking for the sixth nerve, and this is neurotissue there. You got to be very careful as you dissect the periphery of the tumor. And with the stimulator, I know the sixth nerve is right there. So very carefully, we rotate this tumor. And then I follow this all the way to posterior fossa. And very important, if you don't go around this tumor, then you don't resect it. If you just, so see, I'm dissecting here from the medial wall. The fact that we got the carotid skeletonized allows me to medialize the carotid slightly and then follow this tumor posteriorly there. Here, taking the tumor, and then progressively, we took the tumor all the way here with the Q-tip as a retractor, pushing the Gasserian laterally so I can see posteriorly there. That's a very interesting maneuver. And then we can go all the way inside and rotate the tumor that is in the posterior fossa back. And this is the final view. The Gasserian, again, I'm going to go back here just so you see the fibers were lateral. See, this is the main portion of V3 and V2 and the Gasserian. So it was lateralized. So then we plug that with the collagen matrix to avoid the aggressive CSF and cover that with the nasoseptal flat. That's what we've been doing to avoid the CSF leak. And we covered up, and then here seeing the reconstruction. And this is the final view with the complete resection of the tumor from Gasserian and posterior fossa. And all the components of the tumor, you see and this patient is doing very well. He did have, interestingly, after surgery, he did have, let me go back here, he did have meningitis. So this patient had a lot of headache, and I did a head CT. The second day after surgery, he had a little bit of hydrocephalus, and I did a lumbar puncture to measure pressure. I thought he was developing hydrocephalus for some other reason, and actually was meningitis. Without CSF leak, I have only 2 cases in my career that developed meningitis without a CSF leak just because of the surgery. And this is one of them. We treated, and he got cured, and he did very well. Now he's several years out with no recurrence and no deficits. 6 nerves normal, everything went very well. So let's see some other examples. Tumors like this, that they touch the sphenoid sinus. We will come endonasal to take it out. Now that you see this, the carotid is pushed medially. There's a long contact there. This is other pictures on this case. And this became endonasal. See, complete resection, no problem there. It went very well. Now, let's take a look on the situations like the tumor is guarded by the carotid artery. It's like, what would you do? So this is a patient that I learned a lot. So this patient was in his 70s. And it was several years ago, early in my career. And I look at this, I thought I could do everything endonasal. I thought like, oh, I'm brave, I'm going to do this endonasal. So I came through here. And if you look at the difference with this other one, the girl that I showed earlier, the main difference is that there's no pneumatization on the sphenoid. So I actually struggled a lot, and carotid is somewhat pushed forward here, and there's some hyperostosis with minimal pneumatization. I worked through here endonasal. I did what I could. I got into the tumor, but I wasn't able to go around the tumor because of the carotid. So I did just the debulking internally. I was frustrated. In this cut, it looked like I was not even able to do much on that part of the tumor and superiorly. And this patient had a partial 6th nerve palsy and numbness on the face. And after I did this surgery, the 6th nerve got better, so it decompressed, but the face numbness was still there. And in this case, I came back with a peeling of the middle fossa, the preauricular incision. This is V2, this is V3 here, and we're peeling extradurally. And that's the way I access laterally. And then here the debulking of the tumor. And this is the post-op here coming that way. This is a tumor that probably you can also come transorbital. with a lateral approach. It could be endoscopically or with the orbitotomy with the microscope. They will give you this lateral axis as well. I tend to use with the peeling with a more traditional way for these tumors, and that's what I did here. And interestingly, this patient recovered V1, V2, V3 after the open approach. So this is a post-op with a follow-up with no recurrence. Then other cases like this, you see, this is a schwannoma that is kind of quite larger in Meckel's cave, pushing the temporal lobe with this component on the posterior fossa. And if you look at the carotid, I always look at the carotid. And the carotid is basically a shield for endonasal approach. Look, I cannot dissect through here. It's like a shield there. So here, what we're going to do, I did exactly the same as the other case. You see here the tumor in Meckel's cave. Look at that projection. This was actually outside of Meckel's cave, kind of going almost like poking the parenchyma. It was an aggressive. Look at this finger here of tumor. So I did a peeling of the middle fossa as well, combining like a subtemporal approach, and that's what I did. We're able to get all the tumor out, coming with an open approach here. Lateral orbit will be an option to these cases. This is follow-up imaging with a total resection as well. Now, if the tumor is located more posteriorly, and with this relationship with the posterior fossa, that's what we have to consider now, coming with a middle fossa approach with a preauricular incision or a retroauricular incision to take care of this tumor. So this is a historical case here for that, but I like to show this is a case that I actually did with Amin Qassam during my fellowship. This is Dr. Qassam's case actually, but I like to show because it shows the possibility of combining approaches very well. So here we did a endonasal approach attempt with a small opening here, and in this case, Dr. Qassam, I remember very prudently, he said, like, let's stop there, let's not dissect in the posterior fossa. Took the tumor from Meckel's cave coming through the nose, and the decision, she was intact. And then we came back a few days later with this approach. This is not the picture of the, but this is how I do with the linear incision. I learned that from him as well, with the oblique incision here that allows us to then go there with the retrosigmoid approach, take the tumor out. So this is a historical case that I did with Amin. And we were able to combine an endonasal and a retrosig to complete the tumor resection, and the patient was intact. So I think this is something that you should consider for some of the large tumors. The possibility of combination is not, you don't need to pick one approach and completely resect necessarily. As long as the patient is intact, I think staging is an option. And then I saw this lady. This is when here in Columbus, early in my career as well, and I saw this large tumor. If you see here, this is the internal acoustic canal is normal. See, there's no dilation internal acoustic canal, and this large schwannoma of the posterior fossa was going into Meckel's cave. So this is a trigeminal schwannoma that is mainly located in the posterior fossa. We did the same. This lady was pregnant. And this was hard because we had to monitor the baby, and she was hydrocephalic. I put a shunt, and I did this surgery to decompress the brainstem during pregnancy. She did very well. Baby did very well as well. Because I want to get out of there, I left a little residual around the area. We were able to enter Meckel's cave and get the tumor out of there, but there's a little bit of residual around the vessels. Interestingly, I never gave radiation to this patient, and imaging nowadays is exactly the same. There's a little bit of enhancement there, but this is like a 7-8 years later and no recurrence, but there's definitely a little bit of residual. I went quickly because I didn't want a long surgery because she was pregnant. Probably she was not pregnant. I would spend another hour and take the rest, but the reality is that it worked very well for her. I do think that pregnancy with hormones, placenta hormones and everything probably stimulate this tumor, similar that what we see in some meningiomas. They have receptors, and so the fact that she then did very well with no more pregnancy, she decided not to have more kids, and the tumor residue is stable. Now, let's take a look at some other situations where we have tumors going forward. Like, so we have tumors like that invade infratemporal fossa, pterygopalatine fossa, and sometimes even the orbit. So let's take a look at that situation. And for the most part, we use endonasal approaches as well. So here are situations where we will not use a coming from the front. If it is a tumor that is following V3, as you can see here, going all the way lateral to the infratemporal fossa and almost like close to the skin. So if you look at this, like, what is this? Like, this is very odd tumor. So this, we did a preauricular incision, middle fossa approach, follow V3 from Macular's cave down, remove the whole tumor. It was this type of shape, very different. This we didn't do endonasal because the tumor is going almost all the way to the skin. So a preauricular approach, we went all the way there, drilled this middle fossa here, exposed ovale, resect the whole tumor out, and it was a malignant neuromelanocytic schwannoma. So it's important to have that in your differential. And we follow the nerve all the way to the maxilla, basically. Got a complete resection for this patient. This, of course, was followed with radiation and systemic treatment, but this is some entity that you need to be aware. This is the post-op with a great resection for the patient, and follow up like patient did actually well. See, this is 20 months later and with that resection. So this is an open approach. So you have, like Dr. Goto mentioned, you have to indicate what makes sense for the patient. You cannot use one approach, just one approach. You got to think and analyze. So now here, look at this one. Now you got to see this, they invade everywhere. Like, so now you have Gasserian with a supra projection, goes posteriorly here, a lot of a brain edema. More interestingly, patient has also pituitary adenoma. Initially, I was looking at this, I don't know, maybe it's schwannoma that invaded there, but I'll tell you, this was a pituitary adenoma. So I did 2 surgeries in one here. And because of this adenoma, and this patient, interestingly, was being watched and observed by another surgeon, and then he sent it to me with a history of about 7 years observing this only. And now has edema. If you look at this, patient is now getting confused, and also losing vision because of the adenoma. So because there's an adenoma and we see this, I say like, well, let's try endonasal, get the tumor adenoma, decompress the optic nerve. And because we have all this access to the tumor, let's try endonasal and see how much we can take it out. At least we can decompress. We knew this was growing slowly because it's 7 years imaging being observed. It was a very slow growing, but it did grow. This is post-op. We came endonasal and we debulked the tumor in all directions. You see here, we were able to debulk the center. We didn't remove completely, but we were able to take the pituitary adenoma out, and we were able to do a very nice debulking. The edema completely resolved for this patient, and he's doing well. Now I never did radiation, just watching this, and has been probably 5 years out, and he's doing great. Everything improved. He's absolutely normal, back to work. No deficits. He has a little bit of numbness because of the trigeminal lesion, but it's stable since so many years. So that shows you the possibility. When I look at this image, I do think we could have been a little more aggressive and go around this lesion here on the infratemporal fossa coming through the nose. But the reality is that he is intact and the residual is not growing at all. So it was the right surgery for him. He's doing great. Now, I want to show this other video here that we published with this patient. It's also a tumor that I wasn't sure what was actually this tumor. So this is a 49-year-old that started losing vision in facial numbness. So look at this tumor. It came to us with a history of blindness on the left side, and it started going blind or started losing vision on the right side now. And I look at this, initially, my first thought, oh, this has to be a chordoma. That has to be some invasive tumor. It must be coming from the clivus. But then if you pay attention, look at how it really opens V3 here, ovale, and goes down. It really exploded through ovale there. You see the bone is eroded. So it's no, this is bronze absorbed. This is a tumor probably growing for a long time. So we decided to come endonasal for this. And we did a transpterygoid approach, exploring the areas here with understanding all the areas that we can reach. And this is the video. So what we decided to do was to do here, we started with the middle turbinectomy, and we exposed the, like an antrostomy, to really get access to the ventral aspect of the tumor. And I'll show you here, this is the posterior wall of the maxilla. We are approaching. We decided to take the inferior turbinate, posteriorly to get a full access because the tumor was coming down. And with that maneuver, we did a medial maxillectomy. This is with Dr. Corral here, the operating with Rick. And so this part that he is doing for us to have a full access. And this is the view that allowed us to see that projection of tumor that was coming on the back of the maxilla. And then Dr. Corral here, he did a piriform aperture, and he did a little of a Denker's approach to allow us to get a more exposure of basically making the piriform aperture larger with an extension laterally. And then we basically had a little further corridor. Then he did a nasoseptal flap on the contralateral side. All this preparation for us then to attack the tumor. So then we had this view here. This is posterior wall of the maxilla with a medial maxillectomy. This is the hard palate down here. Flap is on the other side. And then I start dissecting here, and I realized that the entire pterygopalatine fossa is actually pushed forward. And the disease is really more posterior. If you go through here, I would cause damage to his, all branches and infratemporal fossa and pterygopalatine fossa. So interestingly, this tumor was soft. So once then I got into the sphenoid, look at that, it was like kind of somewhat suckable, and I was able to go around it. So this is like I removed it with the mucosa, and I went around that tumor in typical schwannoma appearance. Very interesting. Here's dissecting from the planum sphenoidale. There was not even bone there. It was all absorbed. So probably for a long time was there. So I dissected all the way. This is getting posteriorly. See this planum sphenoidale, see the pulsations. And this is middle fossa here. We remove all extra mucosa. So we removed the mucosa that was invaded by tumor. And we got that resected out of there. These are pieces of mucosa with the schwannoma. And we went then from lateral right side all the way to the left. Here's the Doppler, making sure that's the right carotid artery. Here we have the left carotid artery in the field. And then we proceeded by dissecting laterally, even more lateral, as the tumor had that projection in the posterior to the pterygopalatine fossa. So the good thing is that the tumor was somewhat suckable. So I stayed on that plane of the periosteum, and I stay with two suction technique here, exploring all the dura. And now with the 45-degree endoscope, I'm going to the farmost aspect on the left side, behind the pterygopalatine fossa, basically following all there laterally. And that's when the ingoscopes is very helpful, because I didn't remove the pterygopalatine fossa, I just stay behind it. And you can see here, we explore there, like to kind of free up, but we kept the soft tissue that was pushed forward. And this approach allowed us to lateralize the pterygopalatine fossa and go all the way to V3. This is the neuronavigation. We are basically touching the dura of the lateral portion of the temporal right there. Look at that. Very lateral, just by using that corridor that tumor created. So we were basically following the tumor laterally. And we stayed the entire tumor. See, this is dura that was herniating down as we took the tumor out, followed the tumor lateral to superior orbital fissure. Then we dissect even more lateral. So that's like all dura there. There was some tumor going down to the infratemporal fossa. This is where V3 will be coming out. And we went all the way laterally there. And as you can see, the position. We dissect there. This is the dura here, as you can see. And all this tumor that was up there herniated down, like a diaphragma when you're doing a pituitary adenoma. the whole thing came down, the brain pushed down. So this is the diaphragm after it came down at the end of the resection. I spent some extra time peeling from that dura, but it was interesting because it was extradural. The entire surgery extradural, even what we took from macules, there was no leakage because this tumor started more anteriorly. And then we reconstructed with nasoseptal flap that we cover up that entire skull base defect. But again, there was no CSF. So we cover that with the flap. And here's the final view there with the flap located. And you can see here that dura came down with the brain. And patient, it was blind, remember, it continued blind on the left eye, but the right eye completely normal, it normalized. And pathology came as atypical schwannoma. And because of the fact that it was atypical and so aggressive and large, we decided then to do radiation. I gave a spray of radiation because we felt it was too aggressive. And he's doing great, this patient, no recurrence after radiation. It has been probably around 2-3 years, this surgery. Now, I'm going to show you, this is my last case I'm going to show. This is another patient that presented with blindness with this trigeminal schwannoma. So it's something to have in mind as how they can be aggressive in terms of position. They don't invade, but they push so bad. So look how it entered the orbit, macular cave, pterygoid palatine fossa, and this projection down here, the sphenoid, and even posterior to the maxilla, and went down all the way down here in the inferior aspect of the maxilla posteriorly. So really masticator space. If you look at from the front, you see the optic nerve is pushed up. So it's basically dislocating the orbit, it's squeezing the orbit in that component. This lady also presented with blindness on the on left side. In her case, she was not completely blind like the other one, but she was functionally really losing vision that she could not work. You can see how the optic was pushed and squeezed up. So she was functionally blind with this tumor. Investigated, came in from another state, and we did a surgery. Here as well, we did an endonasal surgery, and following the same principles, we debulk the tumor, then we rotate the capsule away from the orbit, away from the infratemporal fossa. One thing that I learned with this is basically just dislodge all the normal anatomy. So if you go through the normal anatomy, you may cause more problems. So going internally, debulking, and then finding the capsule and rotating away from the normal tissue, that's the best technique. And you can see here the post-op for her. This is a follow-up. It looks like we're never there. You can only see the flap here with a little enhancement under the orbit, but really nice resection. The orbit pops back in place. It looks like we're never there. Her amazing recovery on vision, it was spectacular. Like, she is basically a normal lady. Even her trigeminal function is preserved, because if you find a window, you actually stay there. She has a small area of numbness, but it's impressive how all the function, for the most part, got preserved just by following this principle of staying inside the tumor, debulking, and then rotating the tumor, like we do in neurosurgery in general, then dissecting extracapsular for this patient. So I think with this, I finalize here my overview. I think you enjoyed, and I think the main message is that you have to look at case by case and analyze the anatomy and the relationship of the tumor and the structures to then plan the best approach. The resection is the best way to treat trigeminal schwannomas. I don't think either you observe or you take it out. In our practice, we don't do radiation. I think we like to take it out and preserve the structure. I think it's better for the patients. That's our indication in general. And I think you enjoy the fact that trigeminal schwannomas can grow in different directions and allows us to use different approaches to optimize the resection. And again, endonasal, endoscopic, or open, microscopic, or even endoscopic, they complement each other and to offer the best treatment for the patients. And we just had our course here in Columbus, Ohio, and now we're planning for our next one in May 2024. For those interested, please just send me an email and I'll give more information. Thank you so much.
Thank you, Professor. Your lecture is very, very informative, and you presented a nice case of the endoscopic endonasal surgery. I think that I totally agree that your concept of the surgical treatment to trigeminal schwannoma. In some cases, of course, we need transcranial approach, and in some cases, endoscopic endonasal very effective. I have the one question about the tumor located in Meckel cave, but some part protrude posterior fossa. In such case, of course, I sometimes use endoscopic endonasal approach, but some tumor protrude to posterior fossa. It's a bit difficult to pull the tumor anterior side. So how to decide the surgical approach that how expect we can totally resect through the endoscopic endonasal approach, especially the tumor occupy the Meckel cave and partially protrude the posterior fossa. Do you have some message or comment?
Yeah, I think you have to look at the main component of the tumor. I think if the main component is located on Meckel's cave, and you have a small component in the posterior fossa, I think depending on these aspects that I described, if it projects as endonasal or if the carotid guards, I have other examples that I didn't show here where I came with the preauricular middle fossa approach, and that we have a direct access to the component on the posterior fossa as well. We just follow Meckel's with an open approach. You can take it out extradurally. And I usually plug with the collagen matrix that area, and you have access to posterior fossa as well with an open approach. When I'll tell you this, when I showed this series to Dr. Sami, Dr. Sami was really like into going through the back. He was like, well, even if a small component in the posterior fossa, you drill out the suprameatal tubercle, you have access to Meckel's cave, take the whole tumor from the back. So I think there's no right and wrong, Dr. Goto. I think some people have a little more of a familiarity with one approach than the other. I do like the idea of master all the approaches and see what is the best for the patient, right? So I don't like this idea of only one approach. So I tend to go and go through the start, through the approach where the tumor is larger, that I think will be, right? So if it's a large component Meckel's cave, I may do a preauricular, carotid is blocking like I showed one of the cases through the left side, where I came with the middle fossa approach, and I was able to remove middle fossa and posterior fossa component altogether. And I think if it happens that you go endonasal and you leave a piece behind, like I showed in one example as well, then you can complement by coming with the other approach. So I think the message is start focusing on the larger component of the tumor. If you remove everything, great. If you don't, you can always combine with another angle and complement.
Thank you. Your good message. I have the one question from the audience. Dr. Aziz, can you hear me?
Yes. It's a very wonderful presentation. I just have a question about the tumor always, is it go medially? Because when you see the tumor invading the sphenoid sinus, is it go medial to the paraclavial carotid? Because is it always necessary to mobilize the whole carotid when you do removing the schwannoma? Another question is regarding, will always the schwannoma will, because the Gasserian ganglion is interneural structure, and will always the schwannoma will be inside these both layers of the dura, or it go beyond the confines of this dural pocket?
Yeah, good question. So the carotid artery, I don't like anything that you say always must be skeletonized, like the carotid. You gotta look case by case. There will be situations that you may not need, but frequently when you skeletonize the carotid artery, if you need to move the carotid like 1 to 3 millimeters, it allows you to get a little extra room to visualize posteriorly. And particularly if the tumor is going to posterior fossa, when you come in endonasal, that is very helpful. But it's not that mandatory. Like I think you have to look at case by case. And in general, the schwannomas, they are benign diseases that they push, they just dislocate the structure. So they move the carotid. It's very rare that it's going to go around the carotid artery. You will see that though in more aggressive tumors, like I showed the atypical schwannoma, completely rare. Those are the ones that will be more soft and more invasive and may go around it. But in general, the typical trigeminal schwannoma will just dislocate. And if it starts on Meckel's cave, most likely will push your carotid like medially. But it can also push like anteromedial or anterolateral, depending on where the tumor starts. So you have to look at case by case. But in general, you will be working lateral to the carotid artery as these tumors tend to move the carotid medially.
Okay. Thank you. Raja, do you have some comment to this?
Thank you very much. First of all, let me congratulate Professor Prodello for such a fantastic presentation and teaching us such wonderful approaches. There are 2 questions in the chat box. First one is from Dr. Harshad Parekh. He writes, trigeminal schwannomas are mostly extradural. What chances of CSF leak do you get or any cranial nerve palsies post-op?
Yeah, so you may have like a 6th nerve palsy. I think that's my main concern, independent of the approach. You have to have in mind, independent of the approach, the 6th nerve is pushed up. It's really a tumor that starts on Meckel's cave based on the position of the trigeminal nerve. Even if it's a V1 schwannoma, it may go into the orbit, like the case that I showed, start growing in the direction, but dislocating all the structure. So when you do the dissection around the capsule, be very careful. I don't have a case in my series of permanent 6th nerve palsy, but I did have some patients that have a transient 6th nerve palsy when you do these resections. And again, even if you come from posterior fossa, RISA approach, you will not change the position of the 6th nerve in very close contact with the nerve superiorly. So independent of the approach, you got to be careful with the 6th nerve. I don't see an issue with any other nerve. Very rare you will have any other problem. I guess if the tumor is very large, maybe other nerves traveling through the superior orbital fissure. But in general, that's the situation. One thing that I want to say is one thing that I wasn't able to define or to really figure out during the years is if the main residual nerve that is healthy for the trigeminal fibers, if they're more lateral or more medial. And I had both. I had patients that when I opened, the nerve is completely pushed more lateral. I had others that the nerve is more medial. So you got to just try to read the imaging, try to figure that out. But I think, interestingly, following the same principles where if the tumor bulges more medially, probably started more medial on the nerve and the normal fibers are lateral. So following what I gave in the talk, there is a higher chance that you will land where the tumor is and not on the side of the nerve. Because if you do everything open, you will see that sometimes when you do a peeling of the middle fossa, and you will see that V2, V3 are guarding the tumor. And that's when one maneuver that some people do is to have a bifurcation here of the V2, V3 is to cut in between going posteriorly. You will cause deficits, but it will allow you to get to the entire tumor inside Meckel's cave. That you will need to do that if you land on a tumor that is pushing the nerve in your direction. So you have to be aware of that, and that can cause a little bit of more numbness post-op. So trying visualizing where the tumor grows also helps, I believe, in preserving the fibers of the trigeminal nerve. But other than that, these are the main concerns in terms of cranial nerves that I have.
And vision in patients who had compromised vision, how did it fare post-operatively? Did they actually recover fully?
Yeah, so the ones that are partially affected, like the last case I showed, that lady completely improved vision. But the other one that I showed, there was 1 year already of blindness that in the left eye with a large schwannoma that never recovered. So I think it depends on how much damage the tumor has caused, and I think there's always hope if there's a little bit of vision. But one thing I tell everybody in neurosurgery, I think everybody will agree with me, most difficult to preserve vision or any nerve function is when that function is almost gone, right? So if you do surgery on a schwannoma of the, let's say a vestibular schwannoma, and the person already has a palsy on the face partially, that that's going to be the most difficult facial nerve to preserve. Same thing for optic nerves and any other nerve, because that means that nerve is very close to be damaged completely, and preserve that nerve is one of the most difficult tasks in neurosurgery.
Thank you very much. Another question, which is from Kanu O from Nigeria, and he asked, how often or what percentage of your cases require combined approach, and what are your complications like?
Not many for trigeminal schwannomas. I tend to combine more for diseases like chordoma, where there is a spread through the condyle, and I want to make sure I got a complete resection, and those are probably the most common tumor that I combine. Or recently we did like invasive low-grade sarcomas from middle fossa, clivus, and things like that. I will combine endonasal with an open approach. So it's something that we actually doing more frequently, but not much for trigeminal schwannomas. I usually start with the best angle, best approach. It's a very benign disease. So if you need to stage, if in case you leave something behind, it's possible. I don't try to force two approaches at the same time. Will make it more complex, the surgery, maybe more morbidity. So I just start with the one that makes more sense.
Thank you very much. Any questions from my co-host Liu Bun Seng?
Thanks, Raja. Thanks, Professor, for a very nice presentation. I have a 2-question, Professor. You show us a large acoustic schwannoma, cystic schwannoma, and you prefer to use a small linear incision. May I know that decision to make a small incision because of cystic in nature, or because endoscopic approach assisted can deal with any sizes of a tumor of acoustic schwannoma? My second question, Professor, I did hear from expert of endonasal expert that a pneumatization of the sphenoid sinus is no more a problem for those who want to go through an endonasal transsphenoidal approach with the current technology of IGS. May I get your comment, Professor? Thank you.
Very, very good question. So first, I do use that linear incision for acoustics. That one was a trigeminal schwannoma. As I showed, the internal acoustic canal was not dilated. It was a trigeminal schwannoma. But I do a lot of acoustic surgery. Retrosigmoid, I use a linear incision. I don't do the C anymore because I was seeing a lot of atrophy on the muscles. And with the linear incision, I noticed that I can do everything that I normally do for retrosigmoid. So, and those I use microscope most of the time. I still do a lot of microscopic. For posterior fossa, I use assisted endoscopic. So I do microscope surgery, and then I bring the endoscope, Mitaka arm, or even freehand to observe things and then make decisions. But linear incision, I think, goes very well there. And the second question, what was it again? The
pneumatization of the sphenoid sinus.
Perfect, correct, yeah. So the pneumatization of the sphenoid sinus, I agree, is not a problem for pituitary surgery. It's not a problem to go suprasellar. It's not a problem. However, when you have a non-pneumatized sphenoid sinus without pneumatization of the lateral recesses of the sphenoid sinus, you do have a V2 in a Vidian window that it never is spread in that patient. So it makes a difference for lateral approaches. When you're trying to go to Meckel's cave, the proximity, like you don't have a space between even if you drew everything, the VIDIAN and V2, they're closer together. When you have a pneumatization, naturally spreads V2 in from VIDIAN nerve, and you have a better corridor going lateral when you do a transpterygoid approach. But if the patient has no pneumatization there, you were tight on what nature gave you. Even if you drew everything, the proximity of carotid, V2 and VIDIAN is like packed together. And you end up with not a lot of space to work lateral to the carotid there. So that's why pneumatization is a consideration when you're going to Meckel's cave.
Thank you very much, Professor.
Well, thank you very much, and I think we can close it now, and I'll go back to Professor Takeo Goto to hear his final remarks.
Today, the Professor Daniel Polibero presented a nice education to the surgery of trigeminal schwannoma. His message is that to treat the one disease, we have to learn the many options. Endoscopic ACNS are also transcranial. So we can select the suitable approach to the disease. So we not stick to one procedure. So we learn, young neurosurgeons have to learn the many approach, the classical, the open, skull base, and also endoscopic endonasal and keyhole endoscope. So if you learn everything, we have to choose the best procedure to the disease. I feel that thing from the Daniel's lecture. Thank you, this session.
Well, thank you very much, Professor Prodello. So in that case, now we'll close the first session, and I would like to sincerely thank Professor Daniel Prodello for this wonderful lecture and Professor Takeo Goto for chairing this session. Now we'll move on to the second session, and for that I will hand over this podium to Professor Gu Wentao, who will be the chair for the second session.
So good evening. It's my honor to be chair in this ACNS webinar. And in this section, we are happy to invite our guest, Professor Murata from Japan. Professor Murata is the chairman of Department of Neurosurgery in St. Mariana University School of Medicine, Japan. And as we all know, spinal tumor accounts for just a small percentage of all ACNS tumors, and the microsurgical treatment of intramedullary tumor is still challenging. So next, we were happy to have Professor Murata will give us a lecture about the surgery of intramedullary tumors. So let's welcome.
Hello. I show you the slide. Share slide. Okay. Thank you very much for inviting me this web seminar. My name is Hidetoshi Murata, St. Marian University, Kawasaki, Japan. Today I'd like to talk about intramedullary spinal cord tumors, especially about its basics and advances. There are many types of intramedullary tumor. Some are small tumor, some are medium-sized, and sometimes we experienced long, huge tumors. So, regarding surgery for intramedullary tumors, it's ideal to remove as much as possible and preserve spinal cord function. But it's not easy. Why is that? So this is anatomy of spinal cord. There's many tracts in white matter. So red is efferent tract, blue is afferent tract. Here is spinothalamic tract. Here is dorsal column. Red here is pyramidal tract. On the other hand, let's look at gray matter. there are some neural groups called lex lamina. Therefore, access to a spinal cord is limited. So that's why approach and accessibility is very important. So this is spinal cord, sulcus, and fissure. We operating using a spinal cord fissures. So you can see posterior median sulcus and posterolateral sulcus, anterior median fissure, anterolateral sulcus. So among these sulcus, we often use posterior median sulcus and then posterolateral sulcus. Sometimes posterolateral sulcus are near dorsal root entry zone. So, for example, this is ependymoma that grows in concentric growth. So, in this situation, posterior sulcus approach is a good indication. Next case is dorsolateral lesion. Actually, this is a sarcoidosis. For the axis here, posterolateral sulcus approach is good indication. Direct approach. This is a hemangioblastoma case, sapphire tumor. So, in this case, direct sapphire approach is chosen. Parabyte this. It might be possible to use posterior median sulcus approach or direct approach, but anterior approach is direct and simple and safe. Anterior approach. So the pathway of approach is as follows. PMS approach is a major approach, and then sapphire approach. Pyre or sapphire approach is mainly applied to hemangioblastoma. Recently we experienced 132 cases intramedullary tumor, mainly ependymoma, hemangioblastoma, and astrocytoma. Here, basic concept of intramedullary spinal cord tumor surgery is shown. Textbook says wide operative view, preservation of pyre vessels, wide opening of PMS, tumor side retraction and dissection, preserve the spinal cord parenchymal brain. So, you can see many types tumor. We can treat easily as small and medium size tumor, but long lesions and sometimes region close to brain stem or hypervascular big tumor are not easy to treat well. How should we treat? So, yes, tumor around brainstem. So, my topic, today's issue, how should we treat these tumors? Is there any way to facilitate detachment and rejection? So, basic, I talk about basic and advanced techniques to facilitate the tumor dissection. Here, I introduce 10 methods, both side approach, bioabsorbable material, intramedullary stimulation, aspirating dissection, water dissection, optimal approach other than posterior approach, ICG, endovascular tumor embolization, lifting method, stage surgery. I'll talk about them. First of all, both side approach. This is a very simple concept, but very effective way. Usually, we can treat the other side easily, but ipsilateral side can be difficult to reject. So, in such case, we go around to the other side, so we can remove it quite easily. Next, bioabsorbable protective material. We use open cottonoid. Sometimes we used to use cottonoid. Recently, we use bioabsorbable mesh. Commercial name is Bicryl mesh. It's very thin, 0.1 millimeter, non-sticky, and bioabsorbable. It hydrolyzed for 60 to 90 days. So, original purpose of use, reinforcement of defect or fragile parts of organ. For example, lung, trachea, esophagus, intestinal tract. So, for brain or spinal cord, Bicryl mesh is very useful. This case is paracrinoid aneurysm. So we put this seat on the brain. After gripping, the seat can be easily taken off from the brain surface, non-sticky. It's very convenient. Next topic, intramedullary stimulation. We use usually we use transcranial MEP and ACP. We sometimes use intramedullary stimulations. This case is ependymoma. Tractography showed like this. So, in the surgery, we confirmed, we reject the tumor, we confirmed pyramidal tract. But we cannot detect pyramidal tract always. Next topic, aspirating dissection. So the tumor, this technique is effective for adhesive tumor or invasive tumor. Tumor was aspirated with a small suction tube and elevated, coagulated, and reject. We repeated these procedures and reject the tumor. This case is ependymoma. I show the video. You can see a brownish tumor. The tumor adhered spinal cord, especially at the lateral side. we aspirated the tumor little by little, detach the tumor. So we reject aspirating dissection. So we sometimes coagulate the tumor piece by piece dissection. Finally, we remove gross totally. So, this technique is available for brain tumor. This case is acoustic tumor, vestibular schwannoma. She preserved hearing acuity. I show the video. Internal ultrameter was released, and the tumor was aspirate and coagulate and aspirate, dissected. We reject little by little. So aspirate, reject. Aspirating dissection technique. We use sometimes fine needle. We aspirate the tumor. So finally, we remove the gross totally. She preserved hearing acuity. And next topic, water dissection, water jet dissection. So this is a technique in which water stream is applied to tumor interface, and the tumor was detached. This technique effective for especially for ependymoma. Optimal approach other than posterior approach. Previously, I show you this tumor located in ventrolateral side. So almost cases we chose posterior approach. In this case, anterior approach because I'm concerned about pyramidal tract and dorsal column. Anterior approach. We do neck dissection. Cervical corpectomy was performed. Door was opened. Ventral aspect, spinal cord was exposed. Tumor was rejected dorsal to left C7 root. The tumor was gross totally removed. Pier was closed and door was closed. After that, anterior fusion was performed. Postoperative MRI and anterior fusion was performed. This topic, hypervascular tumor. Yes, mainly applies to hemangioblastoma. For hypervascular tumor, we take advantage of three useful methods. The first is use ICG. So we confirm ICG. We detect feeding arteries. So we coagulate feeding arteries first, and gradually detach. Feeding artery is cut. So we finally remove the tumor. ICG is very useful. The second is preoperative tumor embolization, endovascular embolization. So endovascular embolization is very useful, but it's not easy open. But embolization is a powerful supportive tool for surgery. In this case, we use coil and NBCA. The third is lifting method for hypervascular tumor. So the tumor was tuck up nylon thread at a coagulate or embolized side. It's very easy reject. So another case. This is also hemangioblastoma. So we dissect hemangioblastoma. So we coagulated the tumor. So we tuck up the tumor by nylon thread. So ventral feeding artery confirmed easily. Finally, we removed total rejection. Last topic, stage surgery. Stage surgery is applied to huge, big or long tumor. First surgery is only tumor demarcation. And after 1 or 2 weeks interval, so tumor is inflated and bulging, and CSF come into around the tumor. So in second surgery, tumor resection get easier. So this concept is the idea to induce a detachment by time. So time detach the tumor from spinal cord. I showed illustrative case. The tumor range from C2 to T7, 45 centimeter long. We planned two-stage surgery. So in first surgery, we divided PMS and biopsied and demarcated the tumor. Once we closed the door, pathology was ependymoma. So a week later, MRI showed CSF coming around the tumor. In second surgery, tumor resection was easier compared to first surgery. There's CSF space around the tumor. So you can see very fine vessels on the ventral side. It takes long time to show you. So because large tumors. So we can remove gross total laminoplasty. So I'll show you some cases with basic and advanced techniques we have shown. So one case, he's a 27-year-old man who had intramedullary tumor from C3, C6 with extensive edema. So FDG PET showed a little high uptake. I'll show the video. So posterior median approach, posterior median sulcus approach, we protect the spinal cord with bicular mesh, bioabsorbable mesh. Tumor was detected using aspirating dissection. Feeder it was cut. Tumor dissection progressed. We reject little by little. We aspirate the tumor and reject. Finally, we achieved gross total removal. Post-operative MRI shows gross total removal. Pathology was ependymoma, WHO grade 2, MEBRN index a little high. Next case is hemangioblastoma intratracheal cord, about 40 millimeter length. So in this case, endovascular embolization was performed ahead of surgery. So in surgery, bleeding from the tumor is very controlled. Resection is got easier compared to original hemangioblastoma. We are able to split the tumor. Finally, total resection was achieved. Gross total removal. Post-operative MRI. Next case is ependymoma related to neurofibromatosis 2, NF2. So we divided PMS, posterior median sulcus. The tumor little adhered to spinal cord parenchyma. So we decided to reject with two-stage surgery. So 1 week later, tumor was bulged and shortened. In second surgery, CSF come in around the tumor. We reject tumor easier compared to first surgery. So finally, we removed gross total. Post-operative MRI. Next case is also huge tumor, ependymoma from cervical to mid-thoracic level. We planned a two-stage surgery. So PMS was divided. The tumor was detached to horizontal plane, equatorial plane. We didn't detect the tumor at first surgery. So once the door closed and the wound closed, 1 week later, tumor was bulged and shortened. In second surgery, I noticed interesting things. Tumor here, tumor that was here is gone. The tumor has shifted to cranial side. I showed the video. So tumor resection was not difficult. You can see fine vessel, ventral side of spinal cord. Good fine vessel is good preservation, laminoplastic. So postoperative MRI showed a gross total removal. Last case is cervical medullary junction fused tumor. She had neck pain, truncal ataxia, numbness in left upper extremity, sleep apnea. First of all, we tried the biopsy. Diagnosis is diffuse astrocytoma WHO grade 2. MIPA index is about 10%. So we decided to operate with two-stage surgery. In second surgery, tumor boundary was unclear. So we stayed intratumoral rejection. We cannot help staying intratumoral rejection. We finished with near subtotal removal. Postoperative integrated diagnosis is diffuse midline glioma, H3K27 mutant, WHO grade 4. We did chemotherapy and including TMZ, radiation, 42 Gori, and then we administered bevacizumab due to spinal cord and brain dissemination. I'll show you overall results. In parenchymal tumors, gross total or subtotal removal was achieved in 94%. In neurological status, modified McCormick scale was a little deteriorated just after surgery, but after that gradually get improved. Best modified McCormick scale did not show significant difference compared to preoperative status. Not significant. So conclusion, in intramedullary tumor, it's not easy to achieve functional preservation and high removal rates. The basic and advanced techniques described here have the potential to make it possible. Thank you for attention.
Thank you, Professor Murata, for your wonderful lecture about the different approach of the intramedullary tumors and also some techniques in separating the tumors. And I have one question about the staged surgery and how. What are your considerations about the tumors for the staged tumors? Can you give us some suggestions or comments? Thank you.
About stage surgery, and you mean what
kind of tumor will you choose for
yeah. Okay, I see. And good indication is benign tumor such as ependymoma, low-grade astrocytoma, but malignant tumor is not indicated. So because malignant tumor cause dissemination. That's so two-stage is prohibited.
But in our appearance, the most ependymers have the clear boundary with the spinal cord. So in our department, we choose the one-stage tumor resection of the ependymer, no matter the length of it. You show some cases of the 6 length or 8 length segment of the vertebrae, but in our application, we can choose the one-stage resection of the tumor totally in one stage. So I wonder what the major consideration is. You think you can choose a very nice CSF space after the first operation? And then when you resect the tumor in the second operation, how about the post-operative function, spinal cord function?
Oh, spinal cord function, and
yes.
And after first surgery.
Yes. Second surgery.
Second surgery. After second surgery, yeah. Good. And I think two-stage surgery is better than one-stage unblock resection. I think, I guess. So, and step-by-step resection is good for spinal cord, I guess.
The second question is, how about the intraoperative monitoring? SEP, MEP, and do you use the D-wave monitoring?
Yes, I usually transcranial MEP and SAP, sometimes D-wave, and sometimes spinal cord direct stimulation. That's tested.
Yes.
Thank you very much, Professor Gu Wentao and Professor Hidetoshi Murata for this wonderful session. Any questions from my co-host Liu Bun Sen?
Thanks, Raja. Thanks, Professor, for innovative technique that we learned from today's lecture. Professor, may I ask, during the 1 week wait, how do you titrate the dexamethasone, or do you ever use a steroid in those cases while waiting for 1 week, and how you titrate the dose?
Steroids. Intraoperative steroid.
Yes, and also during the 1 week period, waiting period, do you keep the same dose of the steroid?
Dose, yeah. And I use usually and we divide posterior sulcus. When we divide posterior sulcus, we administered dexamethasone 250 milligram intravenous administration by anesthetist.
Okay. During the 1 week, do you give or no? Only intraoperative?
Yes, intraoperative.
Okay. Thank you.
Yeah. Intraoperative, and after operation and some days we use steroid such as betamethasone.
Oh, okay.
Hi.
Thank you, Professor.
Yeah.
Thank you very much. There is one question in the chat box which asks, while dissecting the spinal cord tumor and using MEPs, you find it drops. Do you stop or wait and exercise? Is asking about transient drops in MEP. during
Uh-huh.
surgery? What would you recommend?
Okay, I see. And yeah, MAP decreased, and I stopped the procedure, but I actually continued and the procedure as long as MAP
Returns.
yes.
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 Well, thank you. That is the most common thing and most frequent question to be asked during this webinars. The most common answer is also the same. You wait for some time, raise the BP, and it comes back to normal. So I think we'll go to our honorable chair, Professor Gu Wentao, and here is final concluding remarks.
So thanks again for Professor Murata for this impressive lecture about the resection of the intramedullary tumors for different approach, and also some useful techniques to preserve the function of the spinal cord. So thank you.
Thank you so much.
Well, thank you very much. So in that case, I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Daniel Pravedello as well as Professor Hidetoshi Murata, for their time and support for the ACNS webinars, and also our honorable chairs, Professor Takio Goto and Professor Gu Wentao. Special thanks to our Vice President, Professor Shubin, for broadcasting this webinar on the WeChat channel, and also to my co-host, Dr. Liu Buncheng, for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.